The Subcommittee on Health, Employment, Labor, and Pensions will come to order, please. Welcome, everyone. I will note for the record that a quorum is present. I note for the subcommittee that Congresswoman Jayapal of Washington and Congresswoman Sherfilis McCormick of Florida are permitted to participate in today's hearing with the understanding that their questions will come only after all members of the subcommittee on both sides of the aisle who are present have had an opportunity to question the witnesses. The subcommittee is meeting today to hear testimony and exploring pathways to affordable, universal health care for Americans. This is an entirely remote hearing. All microphones will be kept muted as a general rule to avoid unnecessary background noise. Members and witnesses will be responsible for unmuting themselves when they are recognized to speak or when they wish to seek recognition. I also ask that members please identify themselves before they speak. Members should keep their cameras on. Thank you, Ranking Member. Members should keep their cameras on while in the proceeding. Members shall be considered present in the proceeding when they are visible on camera, and they shall be considered not present when they are not visible on camera. The only exception to this is if they are experiencing technical difficulty and inform committee staff of such difficulties. If any member experiences technical difficulty during the hearing, you should stay connected on the platform, make sure you are muted, and use your phone to immediately call a committee's IT director whose number was provided in advance. Should the chair experience technical difficulty, Mr. Courtney or another majority member is hereby authorized to assume the gavel in the chair's absence. This is an entirely remote hearing once again, and as such, the committee's hearing room is officially closed. Members who choose to sit with their individual devices in the hearing room must wear headphones to avoid feedback, echoes, and distortion resulting from more than one person on the software platform sitting in the same room. Members are also expected to adhere to social distancing and safe health care guidelines, including the use of masks, hand sanitizer, and wiping down their areas both before and after their presence in the hearing room. In order to ensure the committee's 5-minute rule is adhered to, staff will be keeping track of time using the computer's digital timer, which will appear in its own thumbnail picture. Members and witnesses are asked to wrap up promptly when their time is expired. Pursuant to Committee Rule 8C, opening statements are limited to the chair and ranking member. This allows us to hear from our witnesses sooner and will provide all members with adequate time to ask questions. With that, I will now recognize myself for the purpose of making an opening statement. First of all, thank you all, witnesses. Thanks to all the members for attending and for our visitors who are with us as well. Today, we are meeting to explore pathways to help all Americans access high quality, affordable healthcare. Over the past decade, we've made significant progress toward expanding access to healthcare for Americans. Since President Obama signed the Affordable Care Act into law in 2010, more than 20 million Americans secured health coverage, and the uninsured rate has significantly declined. The ACA has also ensured that more than 130 individuals living with pre-existing conditions cannot be discriminated against or denied coverage, 130 million. To expand Americans' access to healthcare during the pandemic, we passed the American Rescue Plan, which has dramatically helped lower costs for families by providing enhanced upfront tax credits to low-income individuals to lower monthly healthcare costs, ensuring premium-free access to silver plans, and eliminating the subsidy cliff so more low and moderate income individuals have access to affordable healthcare. During the last open enrollment period, a record 14.5 million Americans enrolled in healthcare coverage through the ACA and state-based marketplaces. Simply put, the steps taken in the American Rescue Plan made coverage more attainable for millions and these reforms have saved lives. While the US has made progress in terms of coverage over the course of the past decade, millions of Americans remain uninsured or underinsured. This is particularly true for Black, Latino, and low-income Americans, who are even more likely to be uninsured compared to their peers. For more than a decade, some of our colleagues, particularly Republican state attorney generals, have relentlessly worked to erode or eliminate the ACA entirely. While I think all open-minded people recognize that we can always improve on legislation and look back at it, these attacks are unacceptable to the American public. Far too many individuals also continue to be pushed towards low quality and unregulated junk healthcare plans. The ex-Trump administration actively promoted these plans, saddling many Americans with piles of debt. And if Americans don't have high quality coverage, they won't have the care they need. Unfortunately, 12 of these Attorney General-led states, Republican Attorney General-led states, have also yet to expand eligibility for Medicaid to help low-income individuals afford health care, which has left approximately 2.2 million Americans without insurance. In comparison to our peers around the world, our healthcare system is underperforming. According to analysis by the Kaiser Family Foundation, the US spent around 19% of its GDP on healthcare in 2020, whereas the next highest comparable country, the United Kingdom, devoted 13% of its GDP. The same analysis by the Kaiser Foundation found that healthcare spending per person in the US was almost $12,000 in 2020. Whereas the nearest comparable country, Norway in this case, spent less than $7,000. We know that these inflated costs are driven in part by excessive prices for prescription drugs and other health services. Not only does the United States underperform on access, but our peer nations also often better outcomes, better quality care, according to OECD data. Our current healthcare system is broken, and Americans to fix it. The lesson we learned from the ACA and the COVID-19 pandemic is that when we invest in expanding quality healthcare coverage, when we expect providers, insurance companies to perform and have outcomes of performance, we can save lives. That's why Democrats are committed to ensuring all Americans have affordable, high quality coverage. And I certainly hope that all of us in Congress feel the same way and will join our efforts. As our witnesses will discuss today, there are many approaches to expanding access to healthcare and lots of good ideas about how to get there, such as expanding the Affordable Care Act, establishing a public option, or transitioning to a single payer Medicare for all system. Each of these options builds on the progress we've made and helps us achieve our shared goal of affordable, high quality coverage for all Americans. I really hope that this conversation can also draw upon some of our own experiences back home as well in our districts. In California, for example, we have taken a number of steps to improve coverage. I'm proud of what we've done in California. I was proud of being very involved with it as chair of the California State Senate Budget Committee for Health and Human Services, as well as being a member of the policy committee in that body when we implemented the ACA. I'm proud of the success that we've had, and we've had challenges. In Contra Costa County here in San Francisco Bay Area, we even have our own version of the public option, the Contra Costa Health Plan, which I am a proud member of as a county retiree. And I can tell you, I wouldn't be here if it wasn't for them. They've saved my life. This public option competes with commercial insurers and cooperates with commercial insurers. We cooperate with Kaiser, which is a dominant player that started here in the East Bay. We have a collaborative effort that keeps prices low and quality high for everyone in this area. I think it's important that we learn from these and other examples as we discussed how best to deliver the quality healthcare coverage that Americans deserve. I look forward to hearing from our distinguished panel of witnesses, and I look forward to, I know, a robust conversation with my colleagues where we have legitimate differences of opinion, But I really hope, and I hope our experience with pensions in this subcommittee, and I want to thank Ranking Member Allen and Ranking Member Fox for their support in those efforts. For all our differences, there's work to be done, and I hope that we can accomplish real improvements for Americans in healthcare. With that, I'm happy to recognize the Ranking Member for the purposes of an opening statement. Mr. Allen.
Thank you, Mr. Chairman, and thank you to the witnesses here and for everyone participating in this important hearing today. Employer-sponsored health insurance, or ESI, is the bedrock of America's healthcare system. We cover the majority of lives. Despite this, the Biden administration has waged an assault on the coverage that the majority of Americans and their families rely on. As employers struggle to attract talent during the ongoing labor shortage due to the Biden administration's policies, they are increasingly bolstering health benefits to attract and retain talented workers. We know that this recruiting tool works. In fact, 75% of Americans say that coverage played a role in their decision to accept their current job. Further, a new poll released this week found that those with employer-sponsored coverage rate their care 19% more positively than those with coverage under Obamacare. In an attempt to push more Americans into the Affordable Care Act exchanges, Democrats are increasing Obamacare subsidies. If these subsidies get too high and create an unlevel playing field in the healthcare market, employer-sponsored health insurance plans won't be able to compete with Obamacare plans, which will ultimately lead to a public option. And as everyone knows, a public option is simply a Trojan horse for Medicare for all. Democrats' radical Medicare for all and public opinion proposals would destroy most public opinion proposals would destroy most employer-sponsored insurance plans, stripping America of their employer-sponsored insurance and dumping them into a government-run healthcare, and that would be a major mistake. It would worsen the current labor shortage and create a disincentive for work. The vast majority of the 155 million Americans who have employer-sponsored insurance are very happy with their plans. On average, employer-based plans provide richer and more comprehensive coverage relative to ACA plans. Further, when given the option, 83% of employees in the U.S. choose to be on an employer-sponsored insurance plan. The Biden administration's attempt to undermine these plans is a threat to the personal choice and affordable health care, and it will cost taxpayers exponentially more. We should be encouraging less dependence on government assistance, not more. We must resist Democrats' attempt to expand broken, unaffordable programs. The so-called Build Back Better Act would drastically expand ACA and Medicaid eligibility. Obamacare has been breaking promises for over a decade, and throwing more money after bad will not fix this problem. Additionally, these proposed expansions to the ACA would overwhelmingly help wealthy households and exacerbate healthcare inflation. These expansions also won't increase the number of people insured, but they will primarily go to those who already have health insurance. President Biden's socialist tax and spending bill would also allow the Secretary of Health and Human Services to negotiate, if not dictate, the prices of prescription medications. These price controls would reduce the incentive for companies to participate in medical innovation and severely cut back on new life-saving drugs and their development. Companies who don't abide by the negotiated price will face such steep penalties that they would likely be driven out of the market. This will give Americans less freedom and less choice in healthcare. More government intervention won't decrease the cost of healthcare. The best way to make healthcare affordable would be to increase the use of association health plans. These plans have the power to save Americans up to 50% on healthcare costs by allowing small businesses to band together to offer lower cost health insurance. While Democrats want to monopolize healthcare with inefficient government-run plans, associated health plans focus on expanding real health care options to Americans who do not currently have affordable coverage. Simply put, more federal control is the biggest threat to our healthcare system. Socializing healthcare would increase inflation, exacerbate the federal debt, grossly diminish the quality of healthcare, and put Washington bureaucrats in charge of making the healthcare decisions for millions of Americans. Expanding Washington control will not improve our country's healthcare system. It will make it exponentially worse. And with that, I yield back.
Thank you, Mr. Allen. It's now my pleasure to introduce our witnesses. And we'll start with a friend, Mr. Secretary, Dr. Robert Reich is Chancellor's Professor of Public Policy at the University of California, Berkeley. And show you the cup I'm drinking from. Go Bears. Welcome, Mr. Secretary. He's previously served in a number of key positions in the federal government, including as Secretary of Labor under President Bill Clinton, for which Time magazine named him one of the 10 most effective cabinet secretaries of the 20th century. Mr. Secretary, welcome. Please go ahead.
Well, thank you very much, Mr. Chairman, members of the committee and the subcommittee. My name is Robert Reich, Chancellor's Professor of Public Policy at the University of California at Berkeley. Thank you for giving me this opportunity to testify before the subcommittee. Let me just begin by saying it would be hard to invent a more expensive and less effective healthcare system than we have here in the United States. Even before the pandemic, the typical American family was spending more than $6,000 a year on health insurance premiums. If you add in co-payments and deductibles, the doctors, hospitals, and drug companies also charge, that sum increases to $6,400. Add in typical out-of-pocket expenses for pharmaceuticals, and it's at least $6,800. And that's not all, because some of the taxes the typical family pays are for health care too, for Medicare and Medicaid and the Affordable Care Act. Add them in, and the typical household pays $8,975 a year for health insurance. This number does not include what typical workers' employers spend on their health insurance, which might otherwise go to their wages. American spending on health care per person is more than twice the average in the world's other 35 advanced nations. Yet, and here's where we come to ineffectiveness, the United States ranks near the bottom among advanced nations for lifespan and infant mortality. Americans are sicker, our lives are shorter, and we have more chronic illnesses. Canadians, for example, can expect to live an average of almost 4.5 years longer than Americans, even though health care spending per person in Canada is only half as high as in the United States. The connection between the high cost and ineffectiveness of our system is clear. Because healthcare is so expensive, many Americans put off seeing a doctor until their health has seriously deteriorated. Even with the Affordable Care Act, there are tens of millions of Americans who have no health insurance coverage at all. One major reason for the extraordinary cost is the administrative costs involved in private for-profit insurance. About a third of what the typical American pays for health insurance goes to the people who oversee billing and collections. And then, of course, there are marketing and advertising expenses, and the profits that go to shareholders or private equity managers. Replacing private for-profit health insurance with Medicare for all, would lead to far lower total costs, and I'm including premiums, co-payments, deductibles, and taxes. And it would cover all Americans. People could keep their same doctor or other healthcare provider and could buy private insurance to supplement it, just as some people now buy private insurance to supplement Medicare and Social Security. And finally, if the pandemic has taught us anything, it's that we need to decouple health insurance from employment. Losing a job should not mean the loss of a family's lifeline to healthcare. The Affordable Care Act was a good start at reform, but as Medicare and Social Security have demonstrated, we should not have to pay private for-profit insurers boatloads of money to get the insurance we need. Now, I have no illusions this is going to happen soon, but the road we're now on is unsustainable economically, politically, and socially. Eventually, we're going to have some version of Medicare for all. The question is how much unnecessary cost and hardship we must bear before we do. Thank you.
Chair DeSonia, you're still muted, sir.
You can see he's working on it.
Sir, on your screen, do you happen to have, it appears your microphone is connected to the platform, sir. I'm going to try to perpetuate an unmuting action if there are any instructions that just popped up. There you go, sir. I think you should be good to go.
It's the joy of aging and finding the cursor, Bannon. I've talked to those people in Silicon Valley about that. Thank you. I apologize. Now we are going to hear from Dr. George Benjamin. He is the Executive Director of the American Public Health Association. He's also board certified in internal medicine, a master of the American College of Physicians, a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, and a member of the National Academy of Medicine. Dr. Benjamin, the floor is yours.
Mr. Chairman, members of the committee, thank you very, very much. You know, I've had the privilege of practicing medicine for many years and in many, many settings. And interestingly enough, the one thing that I've learned through all of my experience is that coverage matters. And, you know, our nation has been trying to get this right for over 100 years. We have not yet achieved that. There's no question that we can do better. I'm going to spend my time basically just expounding on my written testimony, which you have, to just talk about why coverage matters. There's no question that having an insurance card is your entry fee into getting high quality, affordable health care. You know, numerous studies have demonstrated that fact. You go back to 2002 when the Institute of Medicine found that uninsured adults had fewer preventive screenings, worse clinical outcomes from cancer, cardiovascular disease, HIV, mental illness, and end-stage renal disease. When they did their study, they estimated that about 18,000 premature deaths occurred simply because people didn't have health insurance coverage. And there have been many other studies. One that I'm aware of, because it was published in the American Journal of Public Health, was a journal that my association sponsors, which went to almost 44,000 deaths per year because people weren't covered. We also know that since the passage of the Affordable Care Act and when the Supreme Court decision made Medicaid coverage optional for the states, we in effect have had a natural experiment occurring in our country, where we've had states that have not been covered with Medicaid and didn't expand in other states. We know that, for example, having a personal doctor, which of course is known to be an important determinant of access to care, in individuals from those states that were covered, they were much more likely to have a relationship with a particular physician. In addition, in a series of studies that found Medicaid coverage facilitated more people having a regular source of care, better access to preventive services, better access to well child visits, better access to early diagnosis and treatment, and improved access to behavioral health and treatment for things like substance use disorders. We also know that the all-cause mortality was reduced in states like Massachusetts. When in Massachusetts expanded coverage overall, their mortality dramatically fell. We know that a national goal also was to decrease utilization of hospital emergency departments for non-urgent care. And there have been many studies that have shown that, that we reduce the utilization of emergency departments when we've expanded coverage. We also know that universal healthcare coverage can reduce health inequities and disparities in health. When we expanded CHIP, the Children's Health Insurance Program, which was of course expanded for low-income families who did not qualify for Medicaid, it was associated with increased access to care and reduced racial disparities. We also know that similarly differences in diabetes and cardiovascular disease outcomes by race, ethnicity, and socioeconomic status declined among previously uninsured adults once they became eligible for Medicare coverage. We also know that as we think about these disparities, universal access to care goes a long way to improving health, but the social determinants of health is actually a bigger determinant in many ways, particularly around healthcare disparities. But access is absolutely an essential component of that. We know that also that health insurance coverage can improve the economic well-being of communities. It can create jobs as well. And if there's anything that we've not missed, the COVID outbreak has demonstrated the importance of universal healthcare coverage more than anything else. As you know, we've got over 78 million people that were exposed to this disease who got it. Peak hospitalizations over 150,000 per day, and almost 1 million deaths so far have shown the absolute need for universal healthcare coverage. And when it's time, I'll be happy to take questions on any of these issues. Thank you very, very much.
Thank you, Doctor. Next, we have Dr. Brian Blais. He's the president of Paragon Health Institute. He is previously Special Assistant to the President for Economic Policy at the White House's National Economic Council from 2017 to 2019. He also serves as a Senior Fellow at the Galen Institute and a Visiting Fellow at the Foundation for Government Accountability. Dr. Blais, the floor is yours.
Thank you, Mr. Chairman, Ranking Member Allen, and members of the committee. It is a privilege to testify before you today, particularly since I was once a House staffer. I'm the founder and president of a new think tank, Paragon Health Institute, and my testimony today represents my own views. I will focus on how to achieve more affordable and higher quality health care and coverage. For too many people, health care and coverage are not affordable, for which government bears some responsibility. For example, individual market premiums more than doubled in the first 4 years of the Affordable Care Act, yet plans covered fewer doctors and hospitals. In 2021, the average ACA plan premium plus deductible for a family of 4 was $25,000. Since coverage is cost prohibitive, most enrollees need large subsidies to afford these plans. At the outset, it's important to acknowledge some basic truths. The US does not have a free market for healthcare. Half of US healthcare spending is by government. Most of the rest is impacted by government policy. As government's role in healthcare has expanded, prices have soared. By contrast, in industries where government's role is minimal, inflation-adjusted prices typically decline while quality improves. High healthcare prices and spending that correspond to meaningful health and longevity gains have justification. Some areas of US healthcare, like our cancer survival rates, are exceptional compared to other developed nations. Too often, however, high prices and spending do not correspond to high value and improved health. This is a key problem to confront in health policy. For example, the ACA expanded coverage and significantly increased federal health spending primarily through Medicaid. But American life expectancy declined for 3 straight years after the ACA's coverage provisions took effect. In fact, Americans' life expectancy was lower in 2019 than in 2013. There's too much government bureaucracy in healthcare. Government rules, despite good intentions, often restrict options for coverage and care, stymie innovation, and prevent providers from being able to best meet their patient needs. Government also mismanages programs to an epic degree. Last year, CMS reported annual federal improper payments in Medicaid were $100 billion. There's too much insurance bureaucracy in healthcare. Insurance is important, but having insurance pay for routine and shoppable services leads to overconsumption and waste. People often secure better prices by not using health insurance. One study estimated that cash prices are 40% cheaper than prices with insurance. For healthcare services where third-party payment is limited, such as cosmetic surgery and LASIK, real prices have declined while quality has improved. Moving forward, you should keep a few principles in mind. First, policy changes always have unintended consequences. We should evaluate outcomes, not the intentions behind those policies. For example, many ACA proponents said it would reduce ER visits because patients would find a usual source of care, but the exact opposite happened. ER use surged, often for non-emergent care. Second, when government subsidizes something, it becomes more expensive. Subsidies increase demand, raise prices, and increase total spending, and must be funded by taxpayers. The American Rescue Plan Act expanded the ACA's already substantial subsidies, and in doing so, increased coverage. But most of the benefit went to people already insured, so it was a highly inefficient way to increase coverage. According to CBO estimates, the subsidy expansion cost about $17,000 each year per newly insured person. These subsidies are also inflationary, allowing insurers to raise premiums at taxpayers' expense. Finally, some recommendations. Congress should codify 4 of the previous administration's policies that expanded options without new federal spending. Association health plans allow more small employers the ability to offer coverage to workers. Short-term plans help many Americans who cannot otherwise afford coverage. Individual coverage HRAs enable employers another way to offer health insurance through tax-preferred contributions that their workers use to buy coverage in the individual market. And price transparency rules empower patients and employers to know prices before purchasing services. Congress should also reorient government spending to maximize patient choice and reward value-conscious decisions. Americans should have the freedom to spend their own money on the healthcare and coverage they choose. These policies provide a good start. Thank you again for the opportunity to testify today, and I look forward to your questions.
Dr. Blais, you got a gold star for perfect timing. Very efficient.
Thank you.
You're welcome. Next speaker, our last witness, is Katie Keith, is a visiting professor and director of health policy and law initiative at the O'Neill Institute for the National and Global Health Law at Georgetown University Law Center. She's also a contributing editor at Health Affairs, where she writes extensively about the Affordable Care Act and other topics relating to health coverage. Dr. Keith, the floor is yours.
Thank you so much, Chair DeSaulnier, Ranking Member Allen, and members of the subcommittee. I'm honored to appear before you on a topic that is near and dear to my heart and the need for affordable universal health coverage. My written testimony covers 4 main issues. First, we have made significant progress under the Affordable Care Act. The chair mentioned some of these statistics already, but I think they're worth repeating. The uninsured rate has reached historic lows. We've narrowed racial and ethnic health disparities in coverage and access to care, and we've improved families' financial stability thanks to the Affordable Care Act. The law has also served as a critical part of the safety net throughout the pandemic. Millions of families who would otherwise have gone uninsured have instead been able to enroll in Medicaid or the marketplace and access the coverage they need, including coverage for COVID-19 tests, vaccines, and treatment. Second, the American Rescue Plan Act has built on the important gains we've made under the Affordable Care Act. For 2021 and 2022, the new law provides increased premium tax credits for lower income people, and for the first time extends premium tax credits to middle income families. Unsurprisingly to me, there has been strong demand for this affordable comprehensive coverage. We've seen record high marketplace enrollment of 14.5 million people enrolling for 2022, and nearly 6 million new consumers enrolled in marketplace coverage throughout 2021. The American Rescue Plan Act consumer savings are also significant. Average monthly premiums fell by 23% for healthcare.gov consumers, 1/3 of whom selected a plan for $10 a month or less. Deductibles are also down as a result of the American Rescue Plan, More generous premium tax credits have meant many consumers can afford to choose to enroll in a more generous plan with a lower deductible. As you can tell, these gains are critical, but they could soon be lost if Congress does not extend the subsidy enhancements beyond 2022. Third, there's a continued need to protect consumers from the range of what I refer to as non-comprehensive insurance products. These include short-term limited duration insurance, fixed indemnity plans, accepted benefits, healthcare sharing ministries. There's more detail about each of these types of products in my written testimony, but in general, these products do not offer the protections that patients have come to expect and appreciate under the Affordable Care Act, and these products can and do discriminate against people with pre-existing medical conditions. Sadly, the media has been filled with stories of those who enrolled in these non-comprehensive products only to be left with devastating medical bills after their plan did not cover their care. These products proliferated during the Trump administration, and in my view, they're a particularly ripe area for consumer protection because of the often egregious, aggressive, and misleading marketing tactics that are used to sell these products to consumers. There's also evidence to suggest that some of these non-comprehensive products are being offered as a primary form of coverage in the employer market, which raises significant concerns for workers and their families. I believe that a comprehensive approach is needed to protect consumers from these types of products, and I fear that other efforts by the subcommittee to advance universal coverage will fail if we do not also address these other products. Fourth and finally, we must continue to push ahead on improving access to affordable, high-quality coverage. Congress should extend the American Rescue Plan subsidies, provide a coverage option for low-income adults in states that have not yet expanded their Medicaid program, and support continued access to Medicaid at the end of the public health emergency. As you address the next wave of health reforms, I also encourage the subcommittee to consider high healthcare spending by commercial plans. Previous panelists have hit on this, and my written testimony touches on recent data on these issues, but I want to emphasize that high healthcare costs and high provider prices are increasingly a challenge for those with job-based coverage. As healthcare costs rise, we know employers pass those higher cost employees through higher premium contributions, higher deductibles, narrower benefits, and higher cost sharing. As a result, underinsurance is on the rise, especially for those with employer plans. Congress has tools at its disposal to address high provider prices, and one mechanism to do so would be to create a public health insurance option that pays lower rates and competes alongside private plans. I'll close there, but thank you again for the opportunity to address you, and I look forward to your questions.
Thank you. That was great. Under Committee Rule 9A, we will now question witnesses under the 5-minute rule. I'll be recognizing subcommittee members in seniority order. Again, to ensure the members' 5-minute rule, and I want to thank the witnesses for being so good, is adhered to. Staff will be keeping track of time. Please be attentive to the time and wrap up when your time is over, and remute your microphone. And now I will see if I can adhere to the rules as I recognize myself for 5 minutes. Secretary Reich and Dr. Benjamin, for both of you, First Secretary, you and I both talked about the overall costs and the underperformance of the American healthcare system, and you mentioned a little bit about what we get for that. So the outcomes don't nearly replicate the investments for the Americans. One thing, and Dr. Benjamin in particular, of those outcomes point members to a really wonderful study by the Kaiser Family Foundation about life expectancy internationally, comparing countries for people over 65, and also regionally. Here on the West Coast, the United States would be 13th out of that study in nations, but then regionally, California and the West Coast would be first in the world if it was a country for life expectancy. They're now diving into that. But as somebody who's a survivor of chronic cancer and has spent 4 weeks in an ICU, I've seen the best and the worst of American healthcare personally. The public option we have here as a former small employer owning restaurants, we use that and it's on our exchange. So it helps the employer. So the question for both of you, starting with Secretary Reich, is what do we get out of this? Not just consumers, but our economy and businesses, and particularly small businesses.
Mr. Chairman, the costs overall of healthcare are increasing dramatically. They're now 19% of our entire economy. Within the next 5 years, if present trends continue, we're going to be up beyond 22%. When I say that that's not sustainable, I mean it's not sustainable not only for the individual, it's not sustainable for the nation as a whole, because there are a lot of other things we as a nation need to spend our money on, as individuals and as a country. Pharmaceutical costs are skyrocketing, but it's not just pharmaceutical costs, it is also all forms of hospitalization and medication, as well as tests, machinery, equipment. Now, it has been pointed out, and I think it's true, the United States does have, for those who can afford it, a terrific medical system. That is, like many other areas of our national life, if you are very wealthy, if you are able to spend the money, you can get better health care here than you can almost anywhere else. The problem is that not only is it expensive from the nation as a whole standpoint, but from individuals who are middle income or working class or poor, it is simply unaffordable. And we have a lot of data showing that people, because of mostly the high deductibles or co-payments, but also because they don't have insurance to begin with, do forego the kinds of medical care they need that would have prevented more serious problems, particularly diabetes and certain forms of cancers and other potentially preventable diseases that are extremely expensive to deal with once they get out of control, as it were. So again, Mr. Chairman, both on the standpoint of the nation and on a standpoint of the individual, we are not doing nearly as well as we should. We're on a trend line that is unsustainable, and we are not doing nearly as well as comparable nations.
Dr. Benjamin, outcomes, are we getting what we're paying for?
We're not necessarily by any means getting what we're paying for. And, there are really 4 reasons why we differ from those other nations. Number one, the fact that we don't have universal access to all of our citizens. Secondly, that we focus too much on specialty care and not enough on primary care. We have a much more complex system, both on the finance and the delivery side, and we don't spend enough on the social determinants. A huge difference in what we spend on societal, we don't spend as much on societal needs as other nations.
Thank you. Ms. Keith, you mentioned some of this, but just some of the loopholes that this committee could work on, and I would hope we could work on this in a bipartisan effort, because seems like people are gaming the system, which is all too frequent. So maybe you could expand a little bit on junk health, accepted benefits, short-term plans in the subcommittee, what we can do collectively.
Certainly. So there's many products out there, and I think a comprehensive approach is needed. At a minimum, I think Congress should look to minimum standards. Some of these products might be appropriate, but they're being misused. So there could be ways to tighten up federal definitions and do increased enforcement. So a whole range of options that I'd be happy to talk about further. Thanks.
Thank you. And I'll note for my colleagues, I'm 11 seconds over. And I will now go to the ranking member for the purpose of questioning the witnesses. Mr. Hill.
Thank you so much, Mr. Chairman. And Dr. Blais, of course, I've been staying in close touch with all of our healthcare providers and our hospitals during COVID. It's been kind of amazing to see how public medicine, private medicine can agree on COVID. So I guess we're going to make it all public now. And the fact that, I talk to patients, I don't know, maybe you guys should go to an emergency room on a Friday or Saturday night. People are not happy. They're just not happy with their health care, period. They expect much more. Again, you talk to these folks, but you talk to the providers. Let me tell you something. Our hospitals were operating at 50% capacity during Omicron because of a shortage of providers. We have a terrible, terrible issue in this country. We're losing providers. Why? And they are very unhappy with the way the government is running healthcare. I can tell you that. I don't know of anybody who's not complaining. Mr. Blais, you know, this committee is advocating Medicare for all and other forms of government-run healthcare. And of course, we haven't talked much about the quality of care. It's not surprising because, frankly, the federal government has its issues in dealing with any type of a government program. I mean, most of my constituent services is dealing with a VA healthcare, and I just had two big issues on that in the last week or so. What would Medicare for All do to employer-sponsored insurance, and how would this affect the 155 million Americans currently enrolled in employer-sponsored coverage?
Mr. Allen, I mean, most proposals of Medicare for All that I've seen would outlaw private coverage. The federal government would take over as the single insurer. There would be no more employer-sponsored insurance. And even you would take away Medicare, both Medicare Advantage, where 25 million seniors get their care, as well as traditional Medicare, where there are deductibles, where there is cost sharing, wouldn't fit under the Medicare for All sort of general rubric.
In the previous administration, the Department of Labor made it easier for businesses to band together to form associated health plans. And this rule was in effect for several months until a federal judge ended it. What did you learn about this rule and its effect on healthcare choices for Americans?
The rationale for the rule was to make it easier for small businesses to offer coverage to their workers, to get some of the advantages that large employers get when they offer coverage. That rule was finalized in June 2018. It was in effect for several months. And my written testimony cites a Washington Post story and a study that shows that these plans were comprehensive coverage, typically covered far more doctors and hospitals than ACA plans, and had delivered significant premium savings to employers and employees that were using them.
Yes, you know, it's amazing. We can't even secure our borders. And in fact, we've got more fentanyl that's come over that border that kill every American 7 times over. And we're talking about a government takeover of healthcare. And we lost 100,000 lives to overdoses in this country, largest ever last year, which might be one of the reasons that our length of age is dropping. But you know, I know Obamacare significantly raised individual market premiums, but I was shocked to learn that, for example, a benchmark for a family in Prescott, Arizona was $50,000 a year. You use this as an example, Mr. Blais. Could you elaborate more on the problems with Obamacare and these subsidies?
So you could, people could find this information out on their own too. They could go, there's a subsidy calculator that Kaiser Family Foundation puts out. And yeah, I mean, you could get families that face benchmark premiums of $50,000 or more. And importantly, a benchmark premium only covers about 70% of the plan's spending. So it's going to come with high deductibles and co-payments as well. So there has to be underlying problems with a program that has caused such significant premiums. And because the premiums are so high, the subsidies need to be so high in order for people to afford coverage. And I think we need to get out of the just increasing subsidies, and we should look at what is the underlying driver of the high premiums of these plans.
Thank you, sir. I'm out of time. And Mr. Chairman, sorry, I yield back.
Quite all right, Mr. Allen. Thank you, Rick. We will now go to the very distinguished gentleman from the great state of Connecticut, Mr. Courtney.
Thank you, Mr. Chairman, and thank you to all the witnesses. Professor Keith, I mean, you did a really nice job of explaining the enhancements to the Affordable Care Act under the American Rescue Plan. And there is a big blinking light in front of Congress right now that it's time limited. You know, in terms of trying to understand this issue better, I reached out to my good friend locally, who's an insurance broker, lifelong Republican, but who, you know, was enthusiastic about the ACA in terms of enrolling her clients. She told me a story that she had a couple who in 2020 were uninsured. Their annual joint income was about $70,000, which put them just above the 400% federal poverty level. So the private market did not offer them anything that was of any value or they could possibly afford. We passed the American Rescue Plan. The husband had been laid off, so that brought the premium down to the maximum benefit, which was about $7 a month. And it's a good thing they had it because sadly, both husband and wife were stricken with COVID. The husband lingered in hospital for a long time, was on ventilators, and sadly passed away. And it's a horrific, tragic story, but there is no question that if we had not passed the American Rescue Plan, his widow would be looking at hundreds of thousands of dollars in terms of medical bills. Jen, the broker, told me another story about a dairy farm in our district, again, who in the private health insurance market was looking at about $30,000 for family coverage. With the enhancements, they were able to bring that down to about $50 a month. Again, the margins which the dairy farms operate on, as many of you know, is wafer thin. So they qualified for this assistance. I mean, it's hard to imagine letting those enhancements lapse. And I just wonder if the O'Neill Center has looked at really what the damage that would occur if that were to ever happen.
Thank you so much for that question. I would emphasize, I think, what the American Rescue Plan did is sort of get rid of that subsidy cliff above 400. It's not a free giveaway by any stretch. What it says is that no one should be paying more than 8.5% of their entire income towards premium. So I think it's a huge protection, including for middle income people. And to your point, the biggest benefits have flowed to older middle income people living in rural areas, which is where premiums were the highest before the rescue plan set in. So in terms of the impact, if these subsidies are allowed to expire, people would see premium shock this fall for coverage next year. So many folks who are paying, as I mentioned, a third of healthcare.gov consumers are paying $10 or less for their coverage. They would see those premiums increase. You would have many of those middle income folks who have been able to, purchase coverage for the first time. And there is data that shows that more middle income people came into the marketplace over time as a result of the subsidy. So the impact has been huge. I'm deeply concerned that those impacts, could be undone if these subsidies aren't extended without more lead time for folks to understand.
And I mean, the evidence is all around us. I don't care what district you're from. In your testimony or in your written testimony, Professor, you talked about the fact that a public option, which would help with cost issues, could also be extended to employer-based plans. That, in fact, you could allow employer buy-in, which would, for I think a lot of particularly small employers, would be incredibly attractive. It would help stabilize, what is the largest component of our healthcare coverage system. By the way, I want to thank Professor Reich for helping us when we got rid of the Cadillac tax a couple of years ago. Your outspoken support for that actually, I think, protected a lot of employer-based plans. But again, Professor Keith, maybe you could just sort of talk about whether or not you could design a public option that would benefit small employers.
Yeah, absolutely. There's a whole range of sort of design decisions that would need to be made around a public option. I think one key one is exactly what you touched on. Would you want a public option to be limited to the individual market, available to small employers, or even extended up into the large group market? There's also questions about whether to allow employers to buy in or even let employees on their own buy in. I think all of those would have different implications that need a lot more study and analysis. But I would emphasize, I think, extending some kind of a public option that does in fact lower costs to the group market is going to have the biggest impact for federal savings, for employers, and for families in terms of really bringing costs down.
Great, thank you. And I'm under the 5 minutes mark, so.
You must have gone to really good school in New England. Thank you, Mr. Courtney. I'd now be happy to recognize the ranking member, Virginia Fox. Dr. Fox, floor is yours.
Thank you, Mr. Chairman. Dr. Blais, I've read, and you mentioned in your testimony that life expectancy was lower in 2019 than in 2013, despite the significant rise in government healthcare spending, the implementation of Obamacare and Medicaid expansion. By the way, thank you very much for being here. And I know you have a piece out today that's very informative. And I thank all of our other witnesses too. But what does this drop in life expectancy say about the effect of government and healthcare programs and spending on health? And you've already talked a little bit about it with Ranking Member Allen. So how will proposals like Medicare for All affect health spending and Americans' quality of care? And maybe something you haven't already said.
Thank you, Representative Fox. It's a very important question. When you hear things, statistics that Americans don't live as long as people in other countries, that's true, but there's a lot of differences that account for that surround behavior, social circumstances, genetics. That's really not an indictment on the healthcare system. When we look at things like what happens when people get cancer, the chairman mentioned that he dealt with cancer. Where do you want to be if you have cancer? You want to be in the US. Cancer survival rates in the US are much better than in Europe. If you look at access to care, Americans have much better access to care than people in a lot of those other countries. For instance, a stat between the US and Canada. This is a percent of seniors who waited at least 4 weeks to see a specialist in the past 2 years. In the US, it was 21%. In Canada, it's 59%. So we don't have to wait as long to get access to specialist care in the US. Now, with respect to Medicaid expansion, we had a big expansion of the program starting in 2014. We had a deterioration in American health outcomes after that. I think when you have a big expansion in demand, which you get from a huge coverage expansion, you're going to reallocate healthcare services. So there's only a fixed amount of doctors and nurses. And one of the things that we should focus on, and which I have in my testimony, is what we can do to expand and increase the supply of healthcare. If you just increase demand, you're going to reallocate health services. And you can reallocate healthcare services in a way that is overall harmful by taking care away from those who most need it and providing services to people who least need it. So that certainly happened to some degree. We see with the Medicaid expansion, wait times for care increased, as well as ambulance response times increased. I think it's also important to recognize that people who are uninsured, they can still get health care. If you take a similar person with insurance and a similar to a person without insurance, the person without insurance is receiving 80% as much care as the person with insurance.
That's an excellent statistic. Unfortunately, our colleagues on the other side of the aisle totally ignore the role of individual behavior and responsibility. And when you hold those things constant, you see a totally different picture. Dr. Blais, the Education and Labor Committee was instrumental in the passage of the No Surprises Act, which increased price transparency requirements for insurers. I'm also very supportive of the Trump administration's regulatory actions to increase transparency within the healthcare market. How will increased transparency translate to lower cost coverage for patients and their families?
Sure, Congressman, and thank you for your work on this. I'll keep my answer here brief. Price transparency helps consumers shop. A lot of services in healthcare are shoppable. There are huge price variations among providers, so knowing price information can really matter. And I think price information is also really important for employers in both how they design their benefits and encourage employees to go to high quality, high value providers, as well as holding accountable the insurers that they have administering their plans.
All right, quick question. Inflation's hit a 40-year high. It's a tax on Americans. It's increased every month since Joe Biden became president. How would healthcare proposals like those included in so-called Build Back Better Act exacerbate inflation?
Sure. The expansion of the ACA subsidies is inflationary because above a certain point, the taxpayer picks up the full cost. So the insurer can raise premiums with taxpayers on virtually the full hook. The other part that's inflationary is the federal payments to states. A lot of the federal support for states goes through Medicaid financing. States don't need federal support right now. They have like record revenues, and Medicaid financing just sort of allows states to increase spending in other areas.
Thank you, Mr. Chairman. I apologize for going over also.
It's duly noted, Ms. Fox, and I do take exception to my friend about totally ignoring personal responsibility. I do take responsibility for almost everything. I don't know how I became a member of Congress, but that's my fault. With that, I'll go to Mr. Norcross from New Jersey.
Thank you, Chairman, for holding this meeting, and to our witnesses, really appreciate the input. First of all, I want to start out by thanking those in the healthcare industry for helping us live during this pandemic. 2 years, almost 1 million people dying, and particularly in the beginning, showing up for work every day to keep us alive, and very much appreciate what they've done. But what we've seen is that even in the pandemic, and the number one way that health insurance is applied in this country is through your employer. There was a law passed in 2008 called the Mental Health Parity Quality Act, which simply says if you spend it on the physical side, you need to spend it on the mental side, the mental health. Well, record ODs this year, over 100,000. And as many members have already talked about, it's been rough, particularly mental health. Yet that stigma that they have to break through, access to mental health, even with this law, is still a problem. With the employer-based plans, there's no enforcement ability to speak of by the federal government to hold these plans accountable. I recently introduced, along with my colleague, mental health parity enforcement, which says that they have the ability to investigate and to levy fines where this is going on. People need access to mental health services. It contributes to more problems in our country than most of us realize. Dr. Benjamin, when you look at our healthcare system, and to quote my chairman, are we getting what we paid for in mental health? Is that happening?
Congressman Norcross, no, absolutely not. When I was practicing in the emergency department, far too often patients would come in with somatic symptoms, physical symptoms, when they really needed help for their mental health. When I was Secretary of Health, we never had enough resources to provide services to people in mental health. In fact, it clogged up our emergency departments, people that required care. And in many cases, people knew that they needed help, and yet the services just weren't there. So we really need to have more services, more resources, and as you said, more enforcement, because there are all kinds of service limits on people receiving mental health services. And we don't necessarily do that for somatic care.
Well, certainly you bring up a good point. The way that the system works now, if you're caught, you have to reimburse the system, but there's still no penalty. I just asked my colleagues, when you go down the highway, if you know there's no policeman, I'm sure each of us will stick to the speed limit. We know that doesn't happen. And quite frankly, that is what is happening in mental health. The earlier the access to mental health services, it saves you money on the fiscal side. So this is something that is addressed in Medicare because we don't have that problem. And certainly Medicare for all, this wouldn't be a problem. Again, I want to thank the chairman for holding this hearing, and I yield back the balance of my time.
Thank you, Representative Norcross. Thank you very much for your comments and your advocacy. And I know, having driven with you, you always adhere to the speed limit in New Jersey and other states. All right, now recognize Mr. Wahlberg from Michigan for 5 minutes.
Thank you, Mr. Chairman, and I thank the witnesses for taking part as well. While my Democratic colleagues look for ways to increase government control in healthcare, I, along with my Republican colleagues, believe we should be promoting policy solutions that expand the ability for employers to continue offering high-quality health coverage for their employees. If the committee is serious about exploring pathways to affordable health coverage and not just a Medicare for all approach, that I would encourage them to take up the Association Health Plans Act, legislation I have offered with Republican leaders on this committee that would lower healthcare costs for hundreds of thousands of small businesses, employees, and sole proprietors. Indeed, employers are finding health benefits more important than ever during the ongoing labor shortage, as 75% of Americans say that coverage played a role in their decision to accept their current job. Employers want to offer health coverage to their employees. However, small employers lack the resources and bargaining power of large employers, and therefore struggle to offer comprehensive coverage at an affordable price. By obtaining health coverage through an association health plan, or AHP, small employers will be able to compete with large employers and offer top quality, affordable plans. In 2018, the Trump administration issued a rule that expanded AHPs. That rule has been held up in the courts, and last year the Biden administration continued to thwart that rule by asking the appellate court to hold the appeal. On that basis, Dr. Blais, and it's good to see you again, some critics of the Trump administration's rule say that AHPs provide skinny coverage that fails to adequately meet the needs of employees. After the rule was released and AHPs began to form, was that the case? And secondly, what kind of coverage did AHPs provide?
Thank you, Congressman. It's good to see you again, too. That is not the case. AHPs did not provide skinny coverage. AHPs provided comprehensive coverage. AHPs are employer coverage. It is how you explained it in your opening. It's a way that small employers can get on the same level playing field as large employers. There's a lot of efficiencies when they can do that. There was a study that was done of the AHPs that were formed as a result of the rule. They were mostly through local chambers of commerce. They provided comprehensive coverage. There were no pre-existing conditions exclusions. There was no medical underwriting. It was employer coverage. It was working well for those small businesses and employees.
And it increased health coverage, didn't it?
Yeah, the projections, the CBO did an analysis, and they projected there would be 4 million people in the new AHPs, and that 500,000 of them, 500,000, would otherwise have been uninsured. So here, you're increasing insurance coverage with no new federal spending.
Appreciate that information. Dr. Blais, your testimony discusses how federal government policies exacerbate inflationary pressures in the economy. And you cite the American Rescue Plan's expansion of the premium tax credit as an example. Could you elaborate on how this policy will drive up prices throughout healthcare and the economy?
Sure. The way the subsidies in the ACA work is that they limit the amount of household income that a family has to pay for a benchmark plan. So any price above that benchmark plan is the taxpayer burden. So that enables the insurers, they know this, right? They know that they can raise premiums, and the premium is going to be almost completely paid by the taxpayer. So it gives insurers pricing power. It disincentivizes enrollees to premium increases, and it creates inflationary pressure where you're going to have higher healthcare prices result from that. You also have the Medicaid provisions in the proposals that are also inflationary.
So expanding AHPs really would reduce inflationary pressure, wouldn't it?
It would. It would save the federal money. It would save the federal government money to the extent that people use AHPs, use employer coverage, and not the premium tax credits. Ranking Member Allen talked about the concern with the budgetary cost of the premium tax credits. The tax exclusion, so employer-sponsored insurance is not subject to income and payroll taxes. That reduces federal tax revenue by about $2,000 for each person. The premium tax credits in the ACA are much larger. So as people move from employer coverage to the ACA market, the overall cost grows. If the subsidies are made permanent, I think there's a real risk that a lot of employers are going to drop coverage. so that their workers qualify for these enormous subsidies. And the budgetary cost is going to be really significant, and the
Thank you.
inflationary impacts. Thank you.
I yield back. Thank you.
Thank you, Tim. The chair will now recognize the sage of Utica, New York, Mr. Morelli.
Wow, no one's ever calls me a sage, but Mr. Chairman, thanks. I very much appreciate you holding this valuable hearing to discuss, I think, one of the most important topics. And thanks to the witnesses for their testimony. Prior to coming to Congress, I had the honor of serving in the New York State Assembly as chair of the Insurance Committee, where I worked to expand access to high quality health care for tens of millions of New Yorkers. And I was particularly proud to pass one of the first permanent mental health parity laws in the country. And I appreciate comments by my friend, Mr. Norcross, about that at the federal level. We expanded insurance coverage for mental health services and provided access to those services in our state. We also enacted prior approval of health insurance rates, strengthened the state's MLR or medical loss ratio, supported the expansion of telehealth, required health coverage of people on the autism spectrum, and enacted the ACA. So when I came to Congress, one of the goal of continuing that work to help people get access to high quality healthcare. And I know that protecting that is how we ensure success at work, home, and school. And I wanted to just expand on a couple of questions that were asked. First of all, Ms. Keith, I appreciated your comments. Can you talk about how the Affordable Care Act uses community rating and that the influence of community on health insurance premiums, and some thoughts perhaps as to how the public option, depending on how it's constructed, could be designed to better reflect risk in consumer premiums? And I just should say, Rochester, New York, where I represent, is really the founder of community rating through an aggregation of our business employers decades ago. So if you could just comment on that, I appreciate any thoughts you have on that.
Sure. So the Affordable Care Act's community rating protections really reshaped most states, perhaps other than New York, but really only allows premiums to vary based on 4 factors. So age up to 3 to 1, geography represent, acknowledging that healthcare rates vary and the cost of healthcare differs by geography, whether it's a single coverage or family coverage, and tobacco use up to a certain limit. And so the idea there was, before the Affordable Care Act, in most states, you could face higher premiums because of your gender, because of your health status, because of your family history, not even your own health status. And the Affordable Care Act came in and said, we're not going to allow that anymore. We're going to protect people with pre-existing conditions who are not going to face higher rates. And so it really constrained the factors that insurance companies could use and sort of leveled the playing field for sick and healthy people, if you will.
Great. Thanks so much for your answer. I wondered if Dr. Benjamin, I lead a project back in Rochester, which is trying to have an integrated delivery system for health, education, and social services. You talked about social determinants. One of the things that I struggle with, and perhaps you can offer some insight to, and maybe the other panelists as well, how would you pay for social determinants? How would we find a sustainable way of making sure that those social determinants, which are so critical to healthcare quality, how we would pay for those in a sustainable way?
You know, one of the things that we don't pay enough attention to is managing policy and spending other people's money. And what I mean by that is there's a fair amount of money in the social services system. We just don't coordinate it very well with the healthcare side of the house. So first of all, doing a much better job of coordinating the systems between the healthcare systems and the social services systems we already have, and leveraging those dollars. We also spend a lot of money between those two systems, redetermining people that are already eligible for one system, and we just don't accept that eligibility for the other system. So we spend we frankly waste a lot of time, effort, and staff time and doing these kinds of things that don't necessarily result in really excluding people. It just costs more money.
Well, I would love to come back to you and talk to you a little bit about that, because our goal is to have a single platform where integrated benefit eligibility for healthcare, for social services, and really utilize expenditures and investments in the social determinants to lower healthcare costs, have better outcomes, better experience for people who are in the system. But the challenge is, and I think it's probably a value-based payment system or somehow using some of the insurance premium to be able to pay for it. But it is a bit of sustainability of the model we're building that continues to confront us. And I do think it's probably using health insurance premiums, at least a percentage of it, to help pay for the sustainability of an integrated system of delivery.
Yeah, one way you might want to think about it is because using those dollars to help pay for workers, for example, paying the salaries of folks can help.
Yeah. Well, thank you very much, Mr. Chair. I yield back and thank the witnesses.
Thank you, Mr. Morelli. The chair will recognize the gentleman from Indiana. Congressman, it's yours.
Thank you, Mr. Chairman. Mr. Blais, I wonder if you could speak for a moment about the effects that monopolies in the healthcare sector have on the overall cost of medical services.
Yeah, thanks for that question. I've actually done a lot of work in the state of Indiana on hospital prices there. Consolidation raises prices. It is clear. And consolidation has been growing. It's actually one of the things that we know has happened after the ACA was enacted between 2009 and 2014. Hospital consolidation increased, hospitals acquiring physician practices increased. When hospitals acquire physician practices, one of the problems is you get referrals within that hospital system without competition. It is a clear sort of evidence, agreement across health economics that consolidation significantly increases prices.
Can you quantify it? Is there an easy way to quantify what the share of healthcare price inflation is related to or explained by hospital monopolies?
You know, Congressman, it's not a particular data point that I'm familiar with. I think top of head within a local area, if hospitals merge, I think that leads to higher prices around 10 to 15%. I'm doing that off of sort of memory of some studies I've read.
You mentioned the efforts at the State House and in Indiana this year addressing some of these important issues, but what would be your recommendation at the federal level for members of Congress to address what's obviously a major driver of increased healthcare costs and hospital monopolies?
Yeah, so I think some of it could be antitrust policy. So, and I would, for a resource, in 2018, the departments of HHS, Labor, and Treasury released a report called Reforming America's Healthcare System Through Choice and Competition that has 50 recommendations, allowing FTC to scrutinize the mergers of nonprofits. Right now, they're excluded from looking at nonprofits. Reversing the ACA's prohibition on physician-owned hospitals. Physician-owned hospitals can serve as a competition to traditional hospitals. Price transparency efforts, codifying price transparency so that consumers and employers are able to put more pressure and sort of bring greater sort of benefit design to their healthcare spending. And honestly, there's a lot of things that states do that are anti-competitive where the federal government could look at trying to incentivize states to get rid of things. Probably the most insidious is something called certificate of need laws, where in order to expand healthcare in many states, you have to go before a board, a government board that's often dominated by incumbent providers in order to, bring on more hospital beds or, expand MRI machines.
Can you unpack that a little bit further? If the federal government continues to ignore hospital monopolies and what it does to drive up overall healthcare costs on all American families, what can states do without actions of the federal government?
So states
you mentioned the con laws, but what else?
So states can make sure they don't enact these things called certificates of public advantage. And actually, some states have done this. And certificates of public advantage allow hospitals to escape federal antitrust scrutiny. And it's a move by a lot of hospitals. We've seen this actually in Indiana over the past year with a couple of hospitals there. They're trying to enact these. And I think things like expanded telehealth, expanded scope of practice can help lighten some of the problems caused by consolidation. But you're right to focus here. It's a real problem in American healthcare.
Yeah, thank you very much. I agree. Incredibly important and very helpful. Thank you very much, Mr. Chairman. I yield back.
Thank you, Mr. Banks. We will now go to Representative Wild for 5 minutes.
Thank you, Mr. Chairman. My question is for Ms. Keith. Ms. Keith, last Congress, I introduced the Family Health Care Affordability Act, which would fix the family glitch, a loophole that has prevented some workers from being able to access the subsidies they need to afford health coverage for their spouse and their children. I'm proud to say that it passed the House as part of the Patient Protection and Affordable Care Enhancement Act, but it hasn't yet gotten through the Senate, and I'll keep fighting until we get that done. You wrote about the family glitch in Health Affairs just last year, and I'd appreciate it if you could tell the committee about how the family glitch has prevented workers and their families from accessing affordable coverage.
Yeah, thank you so much for this question. It's such an important issue, and thank you for all your work and leadership here. So under the family glitch, if anyone in your family is offered affordable job-based coverage for themselves as an individual worker, it unfortunately bars their entire family from accessing marketplace premium tax credits, even if that employer offers unaffordable family coverage. So the offer of affordable coverage for one person and only one person bars the entire family from accessing affordable coverage through the marketplace. And the most recent data that I'm aware of on this comes from the Kaiser Family Foundation. It's about 5.1 million people have been affected by this family glitch. More than half of those 2.8 million are children. And this is primarily, family members of low-income workers who don't have any sort of affordable option at this point, and again, are barred from marketplace access. So I think this is a huge, incredible issue and would be a way to increase coverage significantly.
Well, thank you. My next question was going to be, how important it is in the whole context of providing high quality, affordable health coverage. But I think you've just answered that. Do you have any thoughts on other things that can be done to solve the family glitch, other than me personally trying to convince members of the Senate to pass this bill?
I think there's some, potential administrative options that the Biden administration could look into as well. That would be sort of a narrower fix, but there might be some room to fix it there. I guess the one thing I would emphasize in terms of the impact is that, these 5.1 million people, again, primarily children that I'm talking about, they weren't helped. They got no relief under the American Rescue Plan Act either. So again, I think there's a lot of urgency to extending coverage here so that these families have some relief.
Thank you so much for that information. I think it's vitally important. As I said, I'll continue to work and press forward on this, and I look forward to interacting with you in the future. With that, Mr. Chairman, I yield back.
Thank you, Congresswoman. The chair will now recognize Mr. Fitzgerald from Wisconsin. There we go. Mr. Fitzgerald, the floor is yours.
Thank you, Chair. I just wanted to kind of go back to something that we talked about earlier, I guess. And that would be Dr. Blais. I'm a member of the Small Business Committee right now. One of the things that I've been hearing when I talk to a lot of the small business owners in my district as well is the trouble that they're having hiring people. This is not a shock, I think, to anyone. But providing health insurance benefits is obviously one of the incentives that's oftentimes goes along with hiring. In fact, there was an ahps study recently reported that 3/4 of Americans said that employer-provided health benefits played a role in their decision to accept a job. Clearly, employees want health benefits from their employers. What do you think we could do as members of Congress to enable more small businesses to provide more health benefits to their employees? And I'll just tell you a quick story. Many of the chambers of commerce in my district, which I also represented a good portion in the state legislature, that was one of the things that many of those chambers had worked on, was devising a plan that could include their members so they could continue to expand coverage. And I know this is all in light of the Affordable Health Care Act, but just would like your opinion on that. What specifically could we do?
Sure. Well, thank you for that question, Congressman. One of the things that inspired the AHP rule and another rule that I'll talk about, individual coverage HRAs, is that small employers were increasingly not offering coverage after the ACA. So I think off the bat, I would say you could codify that 2018 Department of Labor rule that allows small employers to join together and get the same advantages that large employers get when they offer coverage. Again, CBO said that would be 4 million individuals making access of that coverage, reduce the number of people without health insurance by 500,000. These employers, and more importantly, employees, would be better off. They'd have coverage that is better for them, and many of them would have coverage that they wouldn't otherwise have. The other thing that was really attractive to small businesses was to just get small businesses out of the business of dealing with health insurance so that they could focus on their core business purpose. The Trump administration finalized a rule in 2019 that would allow employers to offer a contribution that their workers could take to buy coverage that worked best for them in the individual market. This is one way to expand worker choice over insurance plans. A lot of workers only get one option when it comes to their health insurance. And that really doesn't make a lot of sense for a lot of reasons. What other major financial product do people only get one choice over? So this would have allowed employers to make this kind. It's really, the analogy would be like 401ks. So the employer provides a contribution. It's tax preferred. It's the same tax advantage as traditional employer-sponsored insurance. The worker takes that contribution and buys a plan that works best for them in the individual market. That rule is expected, we're expected to get about 11 million people using that rule when it's in full effect. And it'll also reduce the number of people that don't have health insurance by potentially up to 1 million.
Yeah, correct me if I'm wrong. Rules to expand association health plans, first short-term limited duration plans, and the individual coverage, HRAs. I mean, there must have been a decision as to why that was a good move. It sounds like you just mentioned some of those. Is there anything else that was considered?
Yeah, I mean, I think it was about maximizing options for middle-class families that have been priced out of coverage because of the ACA, as well as for small employers and their employees that were increasingly not getting coverage through the workplace. So it's giving them more options. They still have the options of the status quo. Nothing affected the options that were already available to them, but just giving them new ways to obtain health coverage that for many of them would be more affordable and attractive.
Very good. Thank you. I yield back, Chairman.
Thank you, Mr. Fitzgerald. The chair will now recognize the gentlelady from Georgia, Congresswoman McBath, for 5 minutes.
Thank you, Chairman DeSanya, and thank you to all the witnesses for being here today to talk about this really vitally important topic. And at a time when so many are suffering financially, lowering the cost of healthcare so everyone can afford the treatment they need is just absolutely essential. Healthcare now accounts for about 20% of our total gross domestic spending. That's a staggering number, and we continue to see it rise across all services. Now, for my question, I want to focus on the cost of prescription drugs. Now, we've seen costs continue to rise at rates much faster than inflation. Prices that have become seemingly divorced from innovation, with even previously inexpensive generic drugs subject to random changes. These are life-saving medications, which I myself, as a 2-time breast cancer survivor, have had the advantage to be able to use. People are having to make unthinkable decisions about whether to purchase their medications or put food on the table or gas in their car. The American people, they're just sick and they're tired of seeing endless price increases while pharmaceutical companies see record profits. And we know that this market needs reform. Drug companies often argue that we already have a system in which prices are negotiated by health plans and pharmacy benefit managers, and therefore it's not needed for the federal government to negotiate directly. However, I can clearly see that the system as it is currently designed is just failing millions of patients in my district and throughout the country. So I just hope we can all be clear. It's taxpayer dollars that go into the discovery of many of these drugs, and it's taxpayer dollars and wages that go towards paying for these outrageous prescription drug prices. And so my question is for Secretary Reich, how would addressing out of control drug prices to bring them more in line with those paid by other countries create a fairer system for the American people? Secretary Reich?
Yes, I'm sorry. Let me just say, Congresswoman, that retail prescription drug spending per capita by country, and I have in my testimony a chart to this effect, is relative to any other advanced country. The United States is spending far more per person. We're up to about $1,500 per person. And there is no doubt, and there are a number of studies, that if the federal government were to use its bargaining power through primarily Medicaid and Medicare, but also veterans, that bargaining power would be substantial in terms of lowering drug prices. Having worked in and around Congress and being Secretary of Labor and so on, I can tell you something that obviously is an open secret. One of the reasons that the pharmaceutical companies are so opposed to allowing the federal government to have that kind of negotiation power at the federal level is because they're afraid that the federal government could actually reduce the increase in drug prices or reduce drug prices overall.
So thank you. And so Secretary Reich, given this significant taxpayer support for the development of new drugs, so then, how do you respond to the arguments by drug companies that high prices are needed to foster innovation?
Well, I don't think that is true. There's a great deal of innovation by drug companies in other countries. Switzerland would be a good example. The National Institutes of Health provide American drug companies with extraordinary help in basic research, not the development side. That's up to the individual companies. But the basic research is paid for by taxpayers, it strikes me as unfair for Americans to, on top of that, bear the highest drug prices in the world.
Well, thank you so much for your answers. And I believe it's past time that we've addressed the rising cost of healthcare and make coverage affordable to all Americans. Access to healthcare is a right. It's definitely a right, and we need to do what's necessary to make universal health coverage a reality. Thank you so much, Chairman. I yield back.
Thank you, Congresswoman McBath. The chair will now recognize the gentleman from Michigan for 5 minutes, Mr. Libby.
Thank you so much, Mr. Chairman. Secretary Reich, let me start with you. I have very fond memories of working for you, sir, when I was the staff attorney for the Dunlop Commission, and then under your direction, fended off Newt Gingrich's effort to undermine the 40-hour work week and so forth. But let's talk about healthcare. We are all united by the difficult reality that we're going to have a loved one, or we ourselves are going to face a serious health scare in our lives. Healthcare is an absolute necessity. It's a fundamental human right. And this pandemic has illustrated the importance of quick and easy access to life-saving cures and preventive medicines, right? But the question remains, if we can make COVID vaccines widely available and free at the point of use, why can't we do the same for other cures and treatments? And we still have, despite all of our efforts, 30 million people uninsured. There's just no question that we need Medicare for all, a national health program to afford everyone excellent health care from when they're born to when they die. So, Mr. Secretary, you're an economist. You know, the US spent $4.1 trillion on healthcare in 2020, according to the data from the Department of Health and Human Services. And that means that healthcare spending accounts for nearly a fifth of our gross domestic product. That's a lot of money. So building off of your testimony, I want to ask you to break this down a little more. When we add up the taxes, the premiums, the deductibles, the prescription drug costs, even after you pay all your other stuff, then they start hitting you with co-insurance and stuff, right? So spending by public and private sectors together, aren't we already paying as much as we would nationally for universal health care? And if we're paying that much, why isn't the system universal for all that money?
Well, Congressman, that is the most important question I've heard today, in the sense that we are not getting nearly our money's worth. We have 30 million people who are uninsured, have no health insurance at all. They don't have any preventive care. Even those who do have insurance are paying co-payments and deductibles that are so high that they are deterred from seeing doctors. That means that they're not getting the preventive care they need, which is driving up the total costs. You know, in the background of a lot of this discussion is an understandable concern about federal bureaucracy, but I want to just bring everybody's attention to the fact that the two most popular programs in history in the federal government are Social Security and Medicare. I mean, people rely on Social Security and Medicare. There's nothing socialist about these things. Social Security and Medicare are paid for out of basically payroll taxes. They are universal in the sense that they are available to everybody who meets certain criteria. With regard to Medicare, it's I should know I am now eligible given my age. You know, why not continue to lower the age of eligibility of Medicare? Why not expand what Medicare can do for people? Why not use the models that are available to us? I think the Affordable Care Act is enormously helpful. It is a step in the right direction, but given the scale of the problem and given how much we are spending as a society, as you say, more than 20% of our entire gross national product, gross domestic product, we can do so much better.
All right, but what about overhead? You know, what's the overhead or the administrative costs of Medicare compared to, you know, the private insurance?
Well, as I suggested in my testimony, there have been a number of studies looking at this specific issue. And what they show is that the overhead, that is basically the administrative costs for private for-profit health insurance, are substantially higher than the administrative costs of what might be called Medicare for all or Medicare generally. And the other aspect of these administrative costs, I mean, because you've got 1/3 of nurses' time, for example, looking at billing,
Yes.
and you've got all sorts of marketing and advertising costs. But there is another aspect to this that was brought up by one of your members just a moment ago, and that is the consolidation. We see in private for-profit health insurance more and more consolidation, which means more and more market power to drive up these costs. And that is another additional burden on many, many Americans.
Well, thanks, Mr. Chairman. Unlike Representative McBath and many others, I'm a bad child and I went slightly over. So I wanted to ask Dr. Benjamin questions too, but we'll submit them for the record. And I appreciate, and maybe he can answer them in writing, and I appreciate your indulgence. I yield back.
Thank you. It's duly noted, Andy, and there'll be consequences outside of the hearing. Congresswoman Haley Stevens. Thank you.
Well, thank you, Mr. Chair, and thank you to our distinguished group of panelists. I couldn't agree with the conversation more that we have a serious problem in the United States of America, even post ACA. with millions of Americans still struggling to afford healthcare, individuals not receiving coverage if they experience a job loss. We saw this play out in the middle of a pandemic, even in a state like Michigan, which embraced the Medicaid expansion and halved our uninsured rate. We still have the sticking point of 6% of Michiganders not receiving adequate healthcare coverage or getting on those junk insurance plans, which is something that this subcommittee and our full committee have explored at length. And I actually, because this hearing has been so elucidating and important to just jumping in on how we give folks adequate coverage, I wanted to drill down on an area that is continuing to expose Americans and Michiganders alike, and that is with regard to the cost of prescription drugs. If you can't afford your prescription drug, you're not getting the healthcare you need. And time again, I hear from individuals, particularly older Americans, as I spend time volunteering through Meals on Wheels or at our various senior centers. And folks tell me, they're afraid to go to the pharmacy to get their prescription drugs refilled, that they've, worked hard all their life and saved for retirement, and now they've got to go back to work just to cover the cost of the prescription drug, be it for arthritis or obviously very famously we see on insulin costs going through the roof. And we know we have a plan to lower the cost of prescription drugs, but Dr. Benjamin, specifically, I wanted to ask you, given your role with the American Public Health Association, how does delaying or skipping medications negatively impact patients? Because we know this is happening.
Well, people get sick, and we know not only do they skip their medications, but they also split them. So you see husband and wives, for example, and partners sharing a medication. I'll take this one today, I'll give you the other one tomorrow. And then you see real significant clinical consequences. Their diabetes doesn't get well controlled. Their hypertension doesn't get well controlled. And that's a big issue. And then if you're totally uninsured, you pay the full cost of that medication.
Right.
For example, Trulicity is a diabetic medication. It's a shot. You take it once a week. It's a great medication. It's for type 2 diabetes. Its list price is over $800. But if you're insured, the price can be anywhere from nothing, depending on the plan you're in, to $30, $40 a month. So these things can be very, very expensive. And the big problem is that when you don't have those dollars, you don't take your medication.
Right. And I'll tell you, I'm in Oakland County, Michigan, and it's obviously I talked about retirees. I know folks who have retired and gone back to work to get that job to just cover that extra cost. But the other point is families. You've got a kid with a rare disease or is taking medication and you lose your job and then you're paying that whole cost. And we're just stressing. And I heard folks on the other side of the aisle talk about inflation, right? And we know costs are going through the roof, and we know we've got a plan to lower the cost of prescription drugs, and we've got it in Build Back Better. We're certainly waiting to take that vote. But are there other ways in which we can rein in out of control drug costs to improve public health in this country?
Well, as the secretary said, allowing the federal government to negotiate for prescription drugs is the way to do this. It is clear with capitalism that we can get these negotiations done. And the volume of those negotiations would control them to a great deal of degree. And the other thing, of course, is limiting their ability to negotiate, to advertise. Would make a big difference. I got to tell you, they spend a lot of money advertising for medications, and that drives up utilization. People now go into their doctor saying, I want to get drug A, which may or may not be the best drug for them. Yeah,
well, I think it's clear if you don't have affordable universal healthcare coverage, you don't have access to your prescription drugs, and you are really left out to dry as a result. So thank you so much, Mr. Chairman, and thank you to our distinguished group of panelists for being here today. I yield back.
Nice job. Under time. I'm now pleased to recognize the chairman of the committee, Chairman Scott. The floor is yours.
Thank you, Mr. Chairman. Mr. Blais, I was intrigued about the option you had where the employer can make a contribution to the cost. I didn't see any barrier to doing that now. As I understand your plan, the employer would make a contribution, the employee would go in the marketplace, get a plan and use the money. Do you expect that contribution to be tax exempt to the employee? Is that the plan?
Mr. Chairman, thank you for that question. It was actually rule changes in the Obama administration made it illegal for employers to make contributions that employees could take to buy individual market coverage. The policy change we did reversed that and set up a set of rules where employers can make these contributions so that workers can buy coverage in the individual market. And yes, they're totally tax preferred. So these contributions aren't subject to federal income or payroll taxes.
To the employee, well, that means they would be getting a benefit from the tax deductibility, from the tax free income for the contribution, and then go and get benefits in the marketplace. So they'd be kind of double dipping.
No, I'm sorry. You can't qualify for both the premium tax credit and the employer contribution. It works just like normal employer coverage. So if you take the employer contribution, you're precluded from receiving a premium tax credit in the exchanges.
So you'd be buying at the exchange at the sticker price with no credits?
You would use the employer contribution, which could be, for a family, it could be $10,000 or more. You take that employer contribution and you would use it to buy an individual market plan. So for the most part, they're probably going to be
Wait a minute, at sticker price with no credits.
Well, you're taking, there's no premium tax credit. You're taking the employer contribution. Basically what this did was it equalized the tax treatment between plans that employers select for all the employees and employer contributions.
Wait a minute, they would get on the marketplace, they would buy it at sticker price with no credits.
Well, they would have the employer contribution. So employers right now contribute to family plans about $15,000 on average. So you could take that $15,000 that the employer is providing, and instead of the employer buying the plan for the employee, they give that money in one of these HRAs. The employee takes that $15,000 and buys a plan in the individual market. It's actually a way to dramatically.
Wait a minute, at sticker price with no tax credits, no reduction for income.
So if the premium is $20,000, the employer contribution would be $15,000. And then the employee would pay the $5,000 on their own. It works just like the way, like a
let me get to
the.
It was a simple question, and I think I got the answer. I'm not sure. On the HSAs, can an association insure a low risk group? The problem with the association plans, of course, is that they pull out a healthy group and pay less, and by simple arithmetic, everybody else pays more. That's the part that people don't talk about.
So the AHP determines who the membership is, but there's no underwriting within.
Yeah,
that
but
group.
it could be a group of healthy people by virtue of their employment. There's no barrier to insuring healthy groups. And if it's not a healthy group, if the costs are more than average, then nobody's going to buy the product. So you have a healthy group, you pay less, and doesn't everybody else pay more?
It works the same way as employer provided coverage works. So if you're a large employer and you're have younger, healthier workers, okay, you're going to pay less. You're self-insured. You're paying less than workforces that are older and sicker. So the thing with AHPs is it's basically just an extension of employer coverage.
So the answer is yes. You would pull out healthy people. They would pay less. Everybody else would pay more. Do they have to cover pre-existing conditions?
Yes.
They have to?
Yes.
Essential benefits?
Yeah, I mean, there's all the HPs are cover comprehensive health insurance benefits.
Wait a minute, essential benefits?
Yeah, I mean, they're subject to the.
Can they place lifetime limits or annual limits on coverage?
No, they're subject to the ACA requirements.
So there's no limit, there's no annual limit, there's no lifetime limit?
Correct.
My time has expired, Mr. Chairman.
Mr. Chairman, I am not going to cut you off. If you want to follow up, please.
Well, if there's no lifetime limit to these HSAs, you have a very serious problem of financial stability, because one sick person can bust the whole operation. And so you have said that you cannot limit, just like a marketplace policy, cannot limit annual or lifetime benefits. That was your testimony.
The AHPs are going to be subject to the same regulations that apply to ACA regulated plans and that apply to employer plans.
Ms. Keith, is that your understanding?
I would say that AHPs have to comply with the large group market rules, at least the way I understand the 2018 rule that Dr. Blais has been talking about. So could not use pre-existing condition exclusions, but you're absolutely right, Chairman, could restrict eligibility, could restrict benefits, and could do selective rating. So higher rates based on age, based on industry, based on gender, would not have to sort of comply with those core, what we think of as individual and small group market protections that were put in place by the ACA. So some ACA protections, but narrow.
What about annual benefits?
The limit on lifetime and annual dollar limits does apply to the large group market. And so that would apply here. But again, there's very few ACA requirements that apply to the large group market, which is where these association health plans would sit.
On an ACA policy, there's no limit. You have to keep paying. You can't stop at a certain level. You have to keep paying. Is that right?
Correct. There's no dollar limits on annual or lifetime care.
Can an AHA have an annual limit?
It shouldn't have, at least not on essential health benefits. But it does not have to cover essential health benefits. You can keep people out. Everything you said about the ability to select risk in healthier people and cause premiums to increase for everyone else is exactly right.
Okay. Thank you, Mr. Chairman. I'm kind of way over.
You're entirely welcome. Nice job for a BC graduate, law school graduate. But I would like to pursue this. I think we've done a lot of work with this in California, and I know other states, to try to help small businesses, particularly restaurants, of which I'm familiar, coming out of COVID. So with that, we will now recognize Congresswoman from Washington, Congressman Jayapal. Welcome to our subcommittee.
Thank you so much, Mr. Chairman, and thank you for allowing me to participate in this incredibly important hearing. So many important points that have been made, and I share Representative Banks' concern about hospital consolidation, increasing healthcare costs, and Mr. Blais' suggestion that the FTC be able to scrutinize mergers among nonprofits is actually exactly what my forthcoming bill would do, something I think will have tremendous bipartisan support. Let me also put an emphasis on Secretary Reich's comment that it would be hard to invent a more complicated and expensive healthcare system than what we currently have, and one that produces some of the worst health outcomes compared to other peer countries in spite of what we spend. During COVID-19, an estimated 27 million people lost their health insurance due to job loss, a perverse tie-in that put a double whammy on working people. Medicare for All would have prevented that and would have ensured that all workers have the health care they need from birth to death, regardless of employment status or socioeconomic status or race, ethnicity, gender, or any other classification that is now used to deny people health care. The committee has a chart that I want to share. And so, Banyan, if you could put that up, thank you so much. This chart is from the Institute of Medicine, and it shows the ranking of US mortality by age group among peer countries. The United States has the highest mortality rate for all ages up to 65 when we rise to the top of the rankings, with one of the lowest mortality rates. It is no coincidence that this happens as soon as Medicare coverage begins. So, Dr. Benjamin, as one of the nation's leading voices on public health issues, can you explain how having stable universal health coverage, such as Medicare, improves health outcomes?
Yeah, coverage matters. The fact that you actually get the care that you need when you need it makes a big difference. The number of times that people do an insurance card biopsy when you first show up to the healthcare center, ask you what your insurance plan is. And it drives a whole lot of things. And quite frankly, the cheapest way to reduce healthcare costs for everybody is to make sure that everybody's covered.
Thank you so much, Dr. Benjamin. Dr. Reich, a couple of questions for you. I want to talk about this tie-in between healthcare and insurance. What harms does a system that tethers health insurance to employment, even with the presence of a public option, present? That's the first question. And then secondly, researchers at the Economic Policy Institute, which you co-founded, found that Medicare for All would increase wages and salaries for workers. Right now, labor unions struggle to bargain for increased wages, while they also have to bargain for adequate health insurance. Can you talk about the effect that Medicare for All would have on labor union bargaining and those wages and benefits that are bargained?
Yes. First of all, Congresswoman, by tying medical insurance to employment, as we now do, we find ourselves, more and more people are tied to their employment. At a time when not only have we been through a pandemic and we've seen how fragile that employment relationship can be, but also we have more and more people who are working part-time, who are contract workers, who are self-employed. We have probably the largest portion of our workforce in terms of growth right now are people who are not tied to individual employers. They really get shut out of a healthcare system that is employer-based. And we need, if you're just looking at trend lines, we need to make sure that they have portable health insurance. Labor unions, you ask, well, labor unions have limited bargaining power, obviously. What they are now doing is using part of that limited bargaining power, not on wages and working conditions, but on healthcare. This is something that if we had an established healthcare system, a Medicare for all system, like most other peer nations do, labor unions would not have to utilize their bargaining power on this particular issue. They could seek higher wages and better working conditions instead.
And it's why we have so many labor unions that are now supporting and have endorsed the Medicare for All Act. One last question. 1 in 6 Americans stay in a job that they don't like to maintain health coverage. So even worse, some people are forced to stay in unhappy and dangerous relationships to keep their health insurance. Secretary Reich, how would Medicare for All affect workers who want to leave their jobs or start a small business or do many other things, but feel that they're unable to?
Well, the job lock is the term we use. And that does mean that many people simply cannot get better jobs. They can't get worker training. They can't get out of relationships that might be abusive. They can't get out of workplaces that they find abusive. They are locked into jobs that they otherwise really shouldn't be locked into for a whole variety of economic and sociological reasons, but it's because of healthcare.
Thank you so much, Secretary Reich and Mr. Chairman. I hope we just continue to add to the number of people that understand we've got to revamp our system, and Medicare for All would provide real health care for everyone in this country. Thank you, Mr. Chairman. I yield back.
Thank you, Congresswoman. Thank you for your passion and leadership on this issue. Next, I'd like to welcome our newest member to the committee and welcome you to this subcommittee from Florida, Congresswoman McCormick, please.
Thank you, Mr. Chairman. Thank you for allowing me to participate today. My question is for Secretary Reich. Opponents of universal health care often use scare tactics to describe such a system, what such a system would look like. They often say that it'll cost too much, that the public sector is less efficient, and that private sector or the government bureaucrats will get in between you and your doctor. Secretary Reich, how would you Reich?
I'm sorry, Congresswoman, I couldn't hear the question. I don't know whether it was my server or not, but could you repeat it, please?
Yes, you froze up for a moment, so if you could repeat the question.
Right at the end. She just froze up right at the end.
Okay, so they often say that it costs too much, that the public sector is less efficient than the private sector. The government bureaucrats will get in the way between you and your doctor. How would you respond to these claims?
If you look at our for-profit private insurance system, and you ask about bureaucracy, concentration, administrative costs, all of the things that very people complain about, or the goblins that are created with regard to government. It is really a maze, M-A-Z-E. Anybody who has ventured into the system knows how complicated and impossible it is to get through. And one thing I tried to emphasize before is that Social Security and Medicare are the most popular programs in the federal government, but they're popular across the board. I don't care whether you're a Republican or Democrat, where you live. I mean, they're popular because they work, because they are relatively simple for people to navigate. Why don't we take something that works, like Medicare, and expand it to deal with a problem that we all have, that we all understand, that really makes our entire system less efficient and less humane, and that is Medicare for all. And I want to, again, compliment those of you who are leading the charge on this. There are very few things that are more important to average working people.
Thank you so much, Secretary Rice, for bringing that up. As a healthcare executive for the last 15 years, I've watched insurance companies become increasingly more confusing for working class people to even try to exercise to get covered or even go through the pre-authorization process, leaving them without health insurance. So I'm happy that you brought up how in some instances, it's actually simpler to go towards a Medicare for all system. Now, do these experiences of the other countries that have universal healthcare systems resemble the scenarios described by our opponents?
If you're still asking me, Congresswoman, there have been a number of studies, very good studies, and I'm happy to refer you to them, that compare the United States system to many other advanced systems and other advanced countries. They're not exactly alike. They are different in many respects. They're not all single payer, for example. They're not all what we would consider Medicare for all, but they all have elements of Medicare for all. And they are, they're not all great. I mean, there are some waiting times, there are some inefficiencies, obviously, but it's all relative. I mean, you've got to compare what they have, what they cost, and how many people they reach, and what job they do with our system. And I think that anybody looking at the data and making that kind of comparison can't possibly conclude anything other than the reality that most other advanced countries do it better, cheaper, and reach more people.
Thank you so much. And Mr. Chairman, I yield my time.
Thank you. And welcome again to the committee.
Did she yield her time?
Yes, I yielded to Chairman Bobby Scott.
Okay, thank you. Thank you. Chairman, Secretary Reich, and I know the ranking member mentioned we can get things done. We did surprise billing together. And so we might be able to do something. Let me ask you about the public option. You indicated in your testimony that the Medicare for all could save 21 trillion over 10 years. The public option wouldn't cover as many people, but could we expect similar cost reductions with a public option that we could with a Medicare for all?
Well, I'm not sure that it would be similar, but the key with the public option, and that is definitely a step that could be taken, should be taken, in my view. The key is to make sure that that public option provides the same sort of insurance coverage that Medicare would provide, and that is that, and we can't create a kind of Medicare Advantage situation in which you have for-profit insurance companies that are raking off and seeking to rake off through their marketing and advertising, just kind of skimming the cream. But if it is a genuine public option, I think that could be a major step in the right direction.
Could I have one follow-up, Mr. Chairman?
Of course, Mr. Chairman.
Thank you. And if the public option is less expensive and more effective, would we necessarily have to eliminate private insurance?
No, and I think this is a false sort of goblin here. It is possible to do Medicare for all itself and still have private insurance. I mean, just like with Social Security, just like with Medicare itself, there are private insurance options. People can supplement what they get, and they keep their same doctors under Medicare. Medicare for all. It can be designed in a variety of ways. I think the key to it is to try to get the private for-profit insurers out of the picture so that people don't have to pay a fortune for the administrative costs, the marketing, the advertising, the profits, the shareholders, the private equity managers, and everybody else who is making a fortune off of our people and our government right now.
When this idea came up first, one senator said it would be unfair competition because the public option would be able to charge less and provide more. My reaction to that is, well, if that's the question, if that's the issue, let's just call the question.
Well, that's right. Bring, Mr. Chairman, you could say, in effect, bring it on. I mean, that's what we want. That's what the public needs.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. And just a comment on the last line of questions. Your predecessor and my predecessor, whose portrait hangs above us, Congressman Miller, he was influential in creating the Contra Costa Health Plan his 40 years in Congress. I'm a member. I've had to use it extensively, as you know, in the last few years. It's not perfect, but it works. And Kaiser and private insurer companies compete with it on a level playing field. If you go to the exchange right now in our area, you can go into it. And as a former employer, I offered this to my employees. And as a former small business employer, in spite of the fact that Kaiser is very competitive, many of them chose it. So it is very frustrating. I hate to be parochial and personal, but knowing that a program works, and this committee helped make it work right now and for 25, 30 years is extremely frustrating. Anyways, with that, I want to really thank everyone for participating. A terrific hearing. Let me read what I am obligated as chair to read, and then I will go to the ranking member for closing comments, and then myself. Again, thank you all. I want to remind my colleagues that pursuant to committee practice, materials for submission for the record must be submitted to the committee clerk within 14 days following the last day of the hearing. So by close of business on March 3rd, 2022, preferably in Microsoft Word format. The materials must be submitted and addressed the subject matter of the hearing. Only a member of the subcommittee or an invited witness may submit materials for the inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record via an internet link that you must provide to the committee clerk within the required time frame. But please recognize that in the future, that link may no longer work. Pursuant to House rules and regulations, items for the record should be submitted to the clerk electronically by emailing submissions to edlabor.hearings@mail.house.gov. And I have one submission that was just texted to me. Before I close on this part, I'd like to submit for the record a letter from Families USA. Again, I want to really thank you all. It's been a terrific hearing, and one I think the subcommittee and the full committee can work on to answer the question, do Americans get what they pay for? And clearly we can agree that they do not. So whatever we can do to make sure that the investment Americans make in their healthcare system gets results that are worthy of this country. Thanks again one last time to this panel. All of you have been great. And I really appreciate it and look forward to following up in our staff. I want to remind once again my colleagues that pursuant to committee practice, witness questions for the hearing must be submitted to the majority committee staff or committee clerk within 7 days. The question submitted again must subject the matter of the hearing. And I want to recognize our distinguished ranking member and thank Representative Allen, as always, for working with me to make these hearings successful and a good product subsequent to the hearings. Mr. Allen.
Thank you, Mr. Chairman. And I ask unanimous consent to enter to the record statements from the American Hospital Association, the Coalition to Protect and Promote Association Health Plans, and the Partnership for Employer-Sponsored Coverage. I also request to enter into the record letters opposing a government takeover of private health care from the following organizations: Corporate Healthcare Coalition, Council for Affordable Health Coverage, Job Creators Network, National Association of Health Underwriters, National Federation of Independent Businesses, and the U.S. Chamber of Commerce. In addition, I request to enter articles opposing Medicare for All from the American Enterprise Institute, the Grace Marie Turner, the Mercatus Center, and the National Taxpayers Union Foundations. Lastly, I'd like to enter into the record public surveys showing that Americans prefer employer-sponsored coverage to government plans from the Alliance to Fight for Healthcare, Americans for Prosperity, and the Heritage Foundation.
Thank you, Mr. Allen. I take it you're yielding back. Thanks again.
No, I'm not. I'm waiting for you without objection, and then I'm going to finish.
Without objection. I'm sorry.
No problem.
Thank you.
Okay. Well, listen, I want to thank the witnesses. We've had some great discussion. But, you know, frankly, nobody at this hearing knows what it actually costs to take care of a patient. We know that healthcare is a partnership between your physician and the patient. And that's the problem. And frankly, I think that's the problem with any type of federal program, is taking away that relationship. And it's a real problem out there. And, you know, if we, like Obamacare, I mean, we promised the American people you could keep your doctor and we were going to reduce the cost. And look what happened. And, you know, we're here talking today about the exploding costs with less outcomes. Yet we're talking about more government programs. I am deeply concerned with the enthusiasm with my Democratic colleagues in their support for Medicare for All or single payer options. More government intervention will not improve quality of care. It will only increase the cost of health care, which we've seen since the government got in this business. According to the Mercatus Center, Medicare for All will cost roughly $32.6 trillion over the first 10 years of implementation, which would require more than doubling all federal, individual, and corporate income taxes. I mean, we can't even pay for our Medicare today. It is running out of money. The Nonpartisan Congressional Budget Office has said that a single payer option would reduce the amount of care supplied and also reduce the quality of care. Over 155 million Americans get their health insurance from their places of work, and the vast majority of them are pleased with their coverage and their care on these employer-sponsored health plans. In fact, a poll from the Alliance to Fight for Healthcare found individuals with employer-sponsored health insurance rate their care 19% higher than those on Obamacare. Congress should be looking for ways to improve this system. Let's get the real data out there. Let's find out, let's peel the onion back, find out who's getting the money here. And rather than replacing this with a more expensive and less effective system like Medicare for All. As we've discussed today, there are many options to real healthcare reform. For example, association health plans would allow small businesses and sole proprietors to offer lower cost health insurance, saving workers upwards of 50% of healthcare costs. I look forward to working on these solutions to expand access and improve the quality of employer-sponsored health coverage. Thank you again to all the witnesses, and Mr. Chairman, it's been a real pleasure to be with you today, and thank you for conducting this great hearing. And with that, I yield back.
Thanks, Rick. I appreciate it, and forgive my not paying attention between my cursor and trying to prepare for closing comments. I apologize. Again, I just want to thank you. This has been a terrific hearing. I want to thank all my colleagues. This subcommittee, I'm very proud to be chair of and be a member of. We have our differences of opinion, but we work in a way that I think the Congress should work to try to find where our commonalities are, and mostly, and this subject is probably it is the most important one. How do we make the system work better? Knowing that we have different perspectives and not biases, but different perspectives. To a Republican witness, Mr. Blais, would like to follow up on the conversation, maybe Mr. Allen, Mr. Fitzgerald, Professor Keith. I thought the dialogue between you and the chairman, it was a good one. And if we wanted, I really worry about small businesses, having spent 35 years in the restaurant business and having many dear friends still in that business coming out of COVID. They're so important. Small businesses are important. I was a member of the California Restaurant Association for a long time. One of the board members used to refer to me as their communist member, but I took that as a badge of honor. But there's got to be a way that we can help small businesses, and they need that help to be efficient and effective. Whether it's through associations or not, I would say I'm not a supporter as we currently are talking about it, but I thought that exchange was a good one. And if we keep our eye on the ball that we want to help Americans, in this case, small business owners, come out of COVID, come out of them successfully, this is a big, big issue for small business. And I personally think it should be nonpartisan. I also want to comment on the conversation of prescription drugs just because it's personal to me. This drug keeps me alive. We've had hearings. I want to thank both Elijah Cummings, because we had many conversations about this when I was diagnosed almost 8 years ago with stage 4 leukemia. Elijah and I, and now Chairwoman Maloney, we've had hearings about this and brought the CEO here. This drug that keeps me and a lot of people with chronic lymphocytic leukemia alive costs $150,000 a year. In Europe, it is less than half of that amount. In Australia, fully loaded, rather than $150 a day, it's $40 a day. So clearly, when I look at that particular drug, and the history of it is much of the research started in the Department of Defense, starting in World War I, actually, with blood cancers. So, and then the American Cancer Institute. So trying to figure out where the base level of research on drugs like this came from, and the benefit we get. Wall Street Journal did a couple interesting stories on this drug, and it just talked about upper income, and imagine poor Americans making life decisions. Dr. Benjamin talked about families sharing drugs, this frequent on this particular drug. So why does it have to be that way? This American taxpayers are risking their lives dying because of our system on prescription drugs, and it's fixable. And even more maddening, and I would think my Republican colleagues would agree with that, clearly we're subsidizing other countries on this drug in particular. So I'd love to have a further conversation about that. And just lastly, since I mentioned Elijah, and somebody else said this, is he used to say, we're better than this. And in this subcommittee on this subject, we're better than this. Americans pay way too much for what they get. And I can speak with experience, and I can speak with experience about bureaucracy and government bureaucracy in my experience. But this system saved my life. 2 years ago, my sons were told by ICU doctors at George Washington after they flew across the country that I would die within the next 48 hours. I'm here because of the healthcare system in Providence, but we can do better. We can do much better, and Republicans and Democrats can do better. So with that, I'd really like to thank everybody. I look forward to continuing to work together. This is not the ending. This is a beginning for this subcommittee. Mr. Allen, I know Representative Fox, let's work together. We can save people's lives and provide a system that we can all be proud of, and particularly for lower income Americans, wherever they live. Trying to get the resources they need is really unthinkable in the wealthiest country in the history of this planet. I look forward again to working with all of you. Thank you again to the witnesses. And if there's no further business, without objection, this subcommittee stands adjourned. Thank you.